A lot of times people vomit before or after syncope. So talking about that, one good thing to do is if someone does pass out, I'd go ahead and just roll them on their side. Just because if they vomit, that way you're protecting their airway a little bit. So if someone passes out in the dental chair, a lot of times if your blood pressure is really low and that's the reason you passed out, you're probably not going to find a radial pulse on them because... So they always say, if I can find a radial pulse on you, your systolic blood pressure is probably greater than 90. If you don't feel a pulse and you don't see breathing, just go ahead and start CPR. Sometimes I think people, it's hard to, like, I don't know if I feel a pulse or not. Usually you can tell if they're breathing. Just go ahead and start CPR.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists. This is episode number 186. My name is Andrew.
And this is Michelle. Welcome back for another wonderful week of this crazy podcast.
Yes.
I gotta say, anybody who listens to a dental hygiene podcast every week, I'm impressed by you. And thank you.
Kudos to you all. Yeah, for sure. I mean, it's a special person that does that, but it is an ever increasing download number that we see every week. So it must be, you know, it's somewhat.
Keep it up.
Yeah.
So we get to see each other in like 4 days or something.
Let's take that part out.
No?
Because we're already there. By the time this releases. Remember how before we started, we said, oh yeah, we're already there?
But we never talk like that.
We always do. Oh, and we're here at the conference. Okay.
No, we always say by the time you hear this, we're going to be at RDH under one roof.
I missed you when you were gone. I just want to say that real quick. I like the arguing. Whatever this is. Like, even though we had a game plan going into it, we both said exactly what we thought was going to happen, and you still did what you thought was going to happen, and I still called you on it, but I thought that's because that's what I thought was going to happen, and that's not what happened.
Our communication does not improve.
You've been gone for too long, and we took a little bit of break and did a whole bunch of intros right away, and that's your fault.
We would have done that anyway.
True. It's true. All that's true. All of this is going to stay in. I don't even care. You know what? I don't care. This is staying in, but as this drops, we are at RDH Under One Roof doing the things.
Yes. We're doing the things. We're at the booth. We're drinking the wine. I'm drinking the wine.
I was going to say, wait.
You're just drinking the Red Bull.
Maybe. Perhaps. We'll see how that goes.
I would love for that not to happen.
We had a pact, everyone, at ADHA, and I was upholding my end of that pact, and Michelle ruined it.
I did. I was going to go without wine. That was my first glass of wine there, like after my surgery. So as I take my sip of my wine.
Oh my gosh. Okay. So we have a lot of things planned though for RDH Under One Roof. It's one of our favorite conferences. And so if you've never been to RDH Under One Roof ever in your life, you have to kind of picture a conference that's geared for hygienists. You're going to have really great CE that's just very specific for hygiene as well. But also I feel like it's ever evolving into kind of like the DSOs and the lasers and kind of the things that are maybe not always talked about at all the bigger conferences. And maybe they are too, but they're very hygiene centric. And then also lots of networking.
Lots of networking and lots of just mingling on the exhibit hall floor, which I think is really fun. They have like their happy hour and stuff amongst the exhibitors, and me being an exhibitor a lot of times, I really do appreciate that. Like, come hang out with us there. And I am you guys have all heard, if you've listened to the podcast, you know how upset I get sometimes with the bad behavior from hygienists at these meetings. So I would just encourage that you go ask good questions. It's not just fill your bag with samples. You can get some good things, but also this is a time to learn and a time to really kind of show them what you actually know and that you're not just a sample grabber, because that's what sometimes these exhibitors think when all they see is a bunch of hygienists with their bad behavior. So go show them how smart you are, ask good questions, and learn a little bit, and then teach them some things too.
Yeah. And also,
it's all fun.
That's soapbox stepping down. And so
stepping down.
We are also going to be at the PDT booth again. It was very popular at ADHA, so we wanted to do it again to get a chance to meet everybody. And what day was it that we're going to be there? Did we figure that out yet?
I believe we're going to be Friday during so RDH has this gap in the exhibit hours of about 2.5, 3 hours or something like that, where it kind of shuts down and everybody can go to classes or take a nap if you need it. I don't know what people do on that break, but then they come back for this happy hour event. And I think it's at 5 that they are going to be starting it. And so we'll be at the PDT booth then, and we're going to be recording, and we want actually everybody to come up and chat with us and come be on the podcast.
We have a very, very specific. So if you guys understand, maybe you've caught it, the first episode of every month, the first Wednesday of every month is a student focused roundtable. So I think what we would like is all of you veterans or even the new grads who have been practicing for just a month or two, come and give advice on the show. And we're going to compile everyone's thoughts into one big kind of longer formatted podcast for the students. So things that you wish you would have known, just your best practices, best advice. So it'll be a chance to get on the show and also kind of give back to everyone.
And also any advice for people going into dental hygiene school or before they've even thought about what do I do? And the reason I say that is because we've been getting quite a few emails. Well, I say quite a few, enough for me to go, maybe we should talk about this, because people who have not, are thinking of a career change actually is the last one that I got. And they are like, where do I even start? I just found you guys. And I'm like, well, that's great that you found us. So they're listening. So any advice that you could give to people who are thinking of a career change, or even we've had some high schoolers call or email us and say, not really sure where to start or if it's worth it. We will take all advice. If we could keep it a little upbeat, that would be great. Because there's plenty of whining on the Facebook. So we would rather keep it upbeat, but we'd love for you to come and record with us.
We have some recent iTunes reviews. Do you want me to read them? It's been a little bit since we've done it.
I only like the nice ones.
All right. 1 star. No, just kidding. Just kidding. That didn't happen. Okay. I can't remember if we read this one yet, but this one says, awesome podcast by Love Trying New Recipes, June 25th, 2019. Sorry, but we're a little bit late on that one. I listen to your podcast when I drive home from work. Thank you for sharing up-to-date information. It's so beneficial to hear education information that I can use in the office or in personal life. Thank you, thank you, thank you. From Love Trying New Recipes, which I like that little title.
I would love for you to bring us the things that you try.
That would be
you can make
awesome.
us things. That would be amazing.
We have another 5-star one. It says, I am a fan by Vivian Villarreal. She says, if you're a hygienist, you need to binge listen to ATOF. Information is relevant and current. The people they interview have such great info. But one of the best things that I have discovered is that if I have a question, the guests are super about getting back to me with an answer. Thanks so much, Michelle and Andrew, for all of your work putting together these episodes. I am a fan. Thank you, Vivian.
Well, thank you. And our guests really are they're amazing for coming on this podcast and just teaching us how to just be better clinicians, smarter clinicians. But they, even after the fact, they are answering questions. But how great are you guys for wanting to ask and inquire and learn more? Good for you. It's good for everybody.
And so the last thing that I have for you guys before we get into the episode today is there is a new dental hygiene podcast. I think it's more of a dental podcast, but it's dental hygiene. You guys know Kara RDH or Kara Bobrovsky from Today's RDH, the online digital publication. But she also has started a new podcast that is taking the articles that they have written and putting them in a digestible format for if you're driving or however you consume your podcasts. So make sure you guys go find that on wherever you listen to your podcasts.
And today we are going to do a podcast or listen to a podcast because this is kind of like completing our series of like the random. I don't even want to say random because it means like that to me feels like it's not important. But this is the CE that not every single state has to have, but we all really need to be listening to. And this one is going to be medical emergencies. Now, this does not fulfill your medical emergency CE, guys. Like you're going to have to go and still get that. But this is at least a digestible amount of info or maybe a nice little refresher. And it's actually going to be with my friend, Susannah, who is a paramedic. So what we were trying to do with this is give you the perspective of the person who would be responding to your medical emergency call and what they would be expecting or some of the things that they are looking for. Because sometimes when you're not doing it every single day, even you take these medical emergency classes and they give you kind of like, this is what you should be doing. And she's like, man, this is how it's really going to go down. So I appreciate Susannah for coming on. You've actually heard her on the podcast before years ago when she went to Nicaragua with me. I think she kind of made a quick guest appearance on some of the audio day journals or something. So this is her second time, but thank you, Susannah Trammell, my BFF, for coming on the podcast.
Hey, Michelle.
Yeah.
It's time for the interview.
Oh, but I had something else to say.
We need to let the experts talk now.
Fine.
All right. Well, let's cheers first.
Okay, cheers.
Cheers to our wine drinking. So first I need a drink first. Mm-hmm. Yeah, I'm not going to miss that sip. Okay. First, I'm only going to say this on the podcast for the millions of people because we're so popular. We have millions of people.
Right.
I'll never say this to your face again, but.
Oh, geez. Let me take another drink.
Let me introduce Susannah, who is my best buddy. Mm-hmm. And I don't know if humanity is better for our meeting or worse.
If what?
Humanity is.
It depends.
If this world is a better place because we're friends.
I think so.
I mean, I think so.
But
I don't know if any of our friends would agree with that.
I think so. I think they do.
Well, Susannah
We
and
entertain
we entertain ourselves.
Mm-hmm.
I wanted to bring Susannah on. We've done multiple trips, and honestly, you're probably the only person I would love to travel with because I never worry about emergencies.
Oh, okay. I was going to say, because I worry about our decision making.
Well, I mean, maybe the emergencies that we create for ourselves,
Right.
but not for other people's emergencies because
Okay.
you're one of the more capable people that I know.
Well, thanks.
You're welcome. I'll never say this again because you better be glad it's
When it's
recorded.
recorded. I'll play it over every day in the morning when I wake up.
So I brought Susannah on, who is my buddy, like I said, because she is a paramedic, flight medic, and all-around badass. I have explicit on this podcast for that reason. So, Susannah, like first to start with your journey. How long have you been a medic of some sort?
A long time. Gosh, I probably started volunteering as just not to say just.
Right. We're learning to say
basic.
not just. Okay. What does that mean?
In college. So in basic, you can pretty much just do CPR, split people's arms. Used to, you could actually intubate as a basic, but they took that away.
Ooh, that's kind of scary.
Yeah. There were a lot of misses. Yep.
Oh, God.
So I did that for a little bit. And then when I moved down to Charleston, I started working EMS with Charleston. And I was actually intermediate, which is they don't even really have that step anymore. But that's the only difference is really you can start IBs as an intermediate. But I did that in North Carolina during college. So I came as an intermediate, started working with Charleston County. And then after about probably 4 years, went to paramedic school. So I have probably been a paramedic.
Like forever.
Gosh, I don't know. A long time.
Very long time.
I worked with Charleston County for about 12 years total. About 3/4 of that probably as a medic. Mm-hmm. And then a flight medic for 4.5.
So pretty much you're like in the helicopters taking care of the people.
Yes.
Yeah.
Yep.
Susannah would encourage you never to call 911.
Unless You're really sure it's an emergency.
Yeah.
Just kidding.
Don't bother the medics. Okay, so the reason I brought Susannah on is because we're going to talk medical emergencies. And I thought it would be a really good idea to have it from the perspective of somebody who is actually going to probably respond to those medical emergencies that we have in the dental office. Mm-hmm. So we're going to do some quick reviews. This is not, I mean, we're going to give CE credit for this, but you are going to need to get your training. And I think there's a little bit more depending on your state. So I would highly encourage you to check your practice acts, and if you're not using CE Zoom to confirm that you're getting all the right CE credits, you need to be doing that. So check those out. And definitely, this is just a good review, though, of all the different things. Because even I have a hard time keeping up. I'm like, oh, stroke or heart attack? Who gets aspirin? I forget sometimes.
Yeah. Well, it's hard when you don't also see things a lot.
Right.
Put it into practice. You learn it, and then unless you're using it, you tend to forget. That happens to everybody.
Yes, absolutely. And I will say, and I think I might have mentioned this on the podcast before, but when I was a newbie hygienist, within probably the first 3 years, I sent at least 3 patients away in an ambulance, which is very unheard of in dental hygiene.
Yeah.
Like,
I definitely remember responding to dental offices when I worked on the street.
Oh, really? Mm-hmm. Why? Like, what was
I'm trying to remember. It wasn't something frequent at all. One, I believe, actually was a sedation type thing where maybe they had some type of
IV
reaction,
sedation,
or they weren't waking up appropriately. Mm-hmm. I really don't remember because it was a long time ago. I just remember responding, but I can't remember all the details.
I definitely sent somebody in a ambulance. One that had a stroke in my chair. One had syncope after with nitrous. She was just a high-strung patient. Got the nitrous, passed out. Yeah. Luckily, she was laying in the dental chair, so she didn't hurt herself. I did have 4. One passed out in the bathroom after oral sedation. Mm-hmm. So there's sometimes you can give IV sedation, and then we'll give just like maybe a Demerol and an Ativan, like oral sedation. I don't even know what the ones are now, but that used to be what we would give. And he went into the bathroom and passed out and fell against the door, so we couldn't even get in there. Oh, yeah. That was rough. And another one, we nicked a lingual artery and ended up tracheing him in the dental chair. Such a fun experience. I learned a lot. Yeah. But I will tell you the first patient that I sent to the hospital, when the paramedics came in, they said, where's their current health history? Yeah. Is that something that you would normally ask from a dental provider?
Definitely. I mean, obviously, if there's an emergency, we're taking care of the patient quickly. I mean, a lot of times you're going to get, now again, depending on where you're at, what state, you're going to get fire department first, just because there's a lot of fire departments closer. Mm-hmm. There are a lot more stations than there are EMS. So a lot of times you'll get fire department first. And even in some states, there are paramedics on the fire department trucks. A lot of them are going to that, but at least you'll probably have like EMT basic, and they're really good at medical. So we'll have help. And when we arrive, usually, or I say on the ambulance, you have 2 people. So a lot of times one person concentrates on the patient while the other person's trying to get information. Okay. Because we want to be able to give the hospital the best turnover we can. So I think it's always a good idea. If you're in the dental office, obviously you have multiple hands. If someone's given care, it does make it quicker for EMS if you can have a sheet of paper, like go ahead and make a copy of their demographics, as well as history, meds, and allergies are like the main things that we need. Okay. Because as soon as we get to the emergency room, the doctor's going to ask us all that. And they want to know, and they can't necessarily look up records. Right. So to have that ready is awesome, and it helps.
And ours are usually electronic at this point. So print it off.
Yeah, just print it off. It's great.
And hand it to you guys. I will say so being a novice, newbie, baby hygienist, when this happened within the first year, I was doing what everyone else in the office was doing, which was just within normal limits, no changes. It's bullshit. We cannot be doing that in hygiene.
Are you talking about for vital signs?
No, we weren't even taking vital signs then, because now we should be doing blood pressure, we should be updating the medical history every single appointment.
Gotcha.
And a new one every year to 2 years, depending on how your office runs, but not just like no changes.
Yeah.
And just go about, because that's exactly what I did. And I felt like a fool when those paramedics came up because they're like, well, are they still on this? Are they still on this? And like, we had just gone through and maybe like crossed it out, added it. It was like such a hot mess of a health history.
Right.
Now, granted, this was 15 years ago, but still, it was the most embarrassing thing to me. So I have always kept a really good medical history. But in that medical history, and I think that's a good point, and I don't know if that would have been in the back of my head to like print that for you guys. Like, whoever was calling 911, be like, BT dubs, print that out. That
like whoever the receptionist is can do that while you're doing things. And even if it's just, even if you write it down, I mean, depending on where you are and everything, obviously that's usually the quickest just to print it out. But if you write down name, birthday, that's great. Social, if you have it.
Something.
And then just medicines, allergies, and any history, you know, because we feel the same way. It's the same thing as when I walk to the ER and I'm like, they ask me questions and
you
I'm
have
like,
no idea.
I don't know. Now, sometimes if I'm picking off someone off the street, there's no family or anything around. There's nothing I can do.
Right.
But I mean, same thing. I've had the same issues. It's like you learn from your mistakes. But yes, that's great to have. And it saves time. And it also it's just like good patient care because it's helping the patient out, you know, to have that because they can't speak for themselves.
Absolutely. Yeah. And what if they can't speak for themselves, literally. So one of the things that we were just talking about, because I asked you about these ASA classifications, American Society of Anesthesiologists have these physical classification systems that we are supposed to be using as hygienists. And you made a really good point. You're like, I wouldn't know these because I am literally picking these people up from wherever they are. But we should know these and we should be able to say these words to you.
Right.
Even if you don't necessarily know ASA 1, we can say, so just to review ASA classifications, we have ASA 1, and you guys Google this, check it out, go to ada.org, or you can go to the American Society of Anesthesiologists and get more information on this. But your 1 is going to be normal, healthy. So your non-smokers, minimum alcohol use, which I would like that defined. I'm not really sure.
So you're definitely not.
I don't know if I'm still in that number, that ASA 1. 2 would be a patient with mild systemic disease. So maybe a current smoker. Oh, here, social alcoholic drinker. Yes, because I only do it socially. Obesity, which I don't know how you tell because that's not maybe something we would know per se. And then well-controlled hypertension. So class 3, so your ASA 3, patient with severe systemic disease. So someone that does not have controlled diabetes or hypertension, maybe they're looking at that chronic obstructive pulmonary disease. They are morbidly obese with a BMI of over 40. And then a history of myocardial infarction or cerebrovascular accident, like your transient ischemic attacks or coronary artery disease. And we will go into that a little bit more on another podcast because there are some very interesting misconceptions about when you can see your patient post cerebrovascular accident. And maybe you hear Lola tapping her little finger or her little paws as she walks around. ASA 4, patient with severe systemic disease with constant threat to life. This is probably not somebody we are going to be seeing unless you are in a pretty decent medical facility or a hospital setting, which we do have a few hygienists out there doing that. ASA 5, patient with imminent risk of death. This is more of the people you probably see. We're going from hygienist to paramedic right here. And 6, patient is brain dead and on life support for organ retrieval purposes, which could be some of the people who listen to this podcast when I bore them to death with research.
Yes.
So these are really good things that we should know. But you're saying that if we were like ASA 1 and we were trying to be smarty pants, you'd be like, I don't really know what that means.
Definitely not.
All right, good.
No.
So just for our records.
Yeah.
Okay. Let's talk about some typical things that are going to happen in a dental office, or maybe some common emergencies in dentistry. And you can kind of tell us what would be a good protocol. And again, what are some of the things that you would expect from us upon arrival? of treating these patients?
For syncope?
Let's talk about syncope first.
So syncope, usually, obviously, they're the same thing as passing out, basically, for multiple reasons. Maybe they've hyperventilated. They've gotten, possibly with dentistry, I know a lot of people get upset and it stresses
super
them
anxious.
out. Yeah. So that could be a medicine because everybody responds to things differently. Low blood pressure. There's so many different reasons that can happen. So basically with syncope, if we came, usually by the time we get there, they're awake anyway.
Ah, okay.
I mean, the main things are if they fell, or were they in the chair when they passed out, or did they fall? Was there some type of trauma? Like, did they possibly hit their head?
Okay.
Was it witnessed or unwitnessed? So did you see them? And so you can tell me maybe about approximately how long they were unconscious, if they're awake. And then obviously if you've taken vital signs, like what you got with vitals.
Maybe even what they were prior to, because we should be taking that BP.
Yeah, what were they prior to?
Okay.
A lot of times people vomit before or after syncope. So talking about that, one good thing to do is if someone does pass out, I'd go ahead and just roll them on their side. Just because if they vomit, that way you're protecting their airway a little bit.
Okay.
Because if they're on their back, obviously they could possibly aspirate vomit, and then you could still suction, but someone being on their side kind of helps it, facilitate going.
Okay.
So yeah, I think those are the main things with.
I mean, is it still the protocol to elevate the feet and things like that?
They kind of change that back and forth, but you definitely, I don't see anything wrong with elevating the feet because it's going to help the blood get back to the heart quicker.
Yeah.
And probably help them wake up a little faster. And it's not going to, lifting their feet's not going to obviously hurt them.
No. Right. Okay.
Cause any damage, I don't think.
Do you think we need to be calling the ambulance for all syncopes?
I mean, the thing with that is if you don't know why, which is probably a lot, you can always call and get EMS on the way. And if for some reason you change your mind, then you can always call
and say, don't
you
come.
Can cancel.
JK.
Yeah, you really can. That happens a lot. They'll cancel us. Usually dispatch is gonna stay on the line until we get there. So whoever's on the line, they really want them to stay on the line until we get there. So you can always say, hey, he's awake now. It's fine. Like, we're going to handle it here. You can cancel. Okay. Also, if you're unsure, you can always have EMS come out. That doesn't necessarily mean they're going to have to go to the hospital. EMS can come out, put them on the monitor. We might have some things maybe your dental office isn't going to have. Check a few more things out. And then you guys are kind of covered, because if they don't want to go or you don't feel like, we'll have them, probably usually sign a refusal. Okay. So we'll still offer to take them, but if everybody feels like it's okay, they can just sign, and that way. So it's not like, you have to go if you call. No. Okay.
I know we're going to talk a little bit about CPR in a minute, but I'm also curious about, in that moment of syncope, obviously don't do CPR on if they're talking to you, as you mentioned earlier.
Don't do CPR if someone's talking.
But I mean, is your first reaction kind of get them on the ground, if they passed out? Like, you just get sleepy by, you're fine. If they're in your dental chair and they are, do you need to get them on the ground? Do you leave them in the chair? And if you roll them on their side, should you be still like checking their pulse until they come to? Like, what would be a good way to do that?
So if someone passes out in the dental chair, a lot of times if your blood pressure is really low and that's the reason you passed out, you're probably not going to find a radial pulse on them, because so they always say, if I can find a radial pulse on you, your systolic blood pressure is probably greater than 90.
Let's remind everyone, where's your radial?
Your radial pulse is in your wrist.
Thank you. Brachial arm.
Brachial's arm.
Carotid neck.
Brachial usually you use on kids or
the babies.
Right. But you can feel brachial in your arm. An obese person, you might have a little trouble.
A little hard time. It's like in that muscle, right?
Yeah, kind of right below it. But I would say radial, and you can even check radial and carotid kind of at the same time. Okay. So if I find a carotid pulse, obviously I'm not going to do CPR. It's always best to have the patient on a hard, flat surface to do CPR. Yeah. Because it's not going to work very well. I mean, your dental chairs, I know, are kind of hard. It's not like they're super cushiony. Like a bed is not going to be a good place to do CPR because the patient's going to.
You're not going to have that rebound,
to move
right?
them to the bed if they can. Yeah. Your dental chairs are probably a little harder, so you possibly could, but I would say go ahead and move them to the chair. To the floor because fire department, if you can, if you have enough people to safely get them to the floor.
Tell me that what you just said again, if you can feel the radial pulse.
So if you can feel a radial pulse, then you can assume that the systolic is probably at least 90 or above.
Okay.
Or vice versa. If you can't, then it's probably less than 90. It's probably low blood pressure.
Okay.
Or they either don't have a pulse. So that's why you check the carotid. And sometimes it's hard to feel a pulse. So if there's any doubt, so I teach CPR as well. So what we teach is if you find someone down, always, of course, have to say scene safe, which does come into play, if you're out in public, but in the dental office, hopefully that's, the case. You want to call and get somebody calling for help. But anyway, you want to check their pulse for 5 to 10 seconds, no longer than 10 seconds. And you can check at the same time to see if they're breathing. So look for chest rise. You can put your head down there, see if you hear them breathing, and check, I would say, carotid pulse.
Okay.
If you don't feel a pulse and you don't see breathing, just go ahead and start CPR. Sometimes I think people, it's hard to, I don't know if I feel a pulse or not. Usually you can tell if they're breathing. Just go ahead and start CPR. If they're awake, they'll
wake up. Wait a second. Can I do that knuckle thing on the chest?
You can if you want
that you've done to a friend of ours when he was intoxicated, which I thought was hilarious.
So what we do is we have AVPU. Do y'all have that? AVPU?
Like
so it's alert.
Oh, no.
So A is for you're alert right now because you're talking to me.
Yes.
V is verbal. So if someone's laying there and their eyes are closed and I say, hey, Michelle, you open your eyes and you talk to me, you're responsive to verbal stimuli.
Okay.
Painful is, so you're not responding to me calling your name. So the next thing I'm going to do is do some type of painful stimuli. So that would be, it could be multiple things. We always used to do, it's called like a sternal rub because that usually
doesn't feel
hurts,
great.
Doesn't feel good. So if you wake up to that, you're alert to painful.
Okay.
If you don't wake up to that, then you're unresponsive.
Okay.
Which, I mean, you could obviously still have a heart rate and everything. You're just unresponsive for whatever reason.
That's interesting. I've never heard that before. So let's talk anaphylaxis. Patients who experience severe allergic reactions. What should we be doing with those people?
So you can have allergic reaction, but it not necessarily be anaphylaxis.
Okay.
If you have we always defined anaphylaxis is they're either, I think there's a combination. You're hypotensive. Usually if you have a stethoscope and you listen to lung sounds, you're going to hear like some rhonchi or some type of, it's not going to be clear.
Okay.
Basically.
Kind of gravelly.
And they're going to have trouble breathing, but hypotensive. So that's anaphylaxis. So,
got it.
Allergic reaction, people can have some type of reaction, but it's not necessarily anaphylaxis. A lot of people who have allergies obviously carry an EpiPen. So if they have one, you can help them administer that. Usually it just sticks right in the thigh. They stick it in the thigh.
So not Horrible Bosses style where he stabbed him repeatedly in the chest.
Yeah, no, usually it's in the thigh. They tell.
Okay.
So in the dental office, do you know if they have an EpiPen or they carry Epi in the
So we're going to touch on medical emergency kits, but we should, I feel like that's a reasonable thing to have. And I think also mentioning checking that expiration date on your medical emergency kits is going to be really important too.
Right. Definitely check expiration dates. We used to always have to check off every morning, obviously all our supplies, make sure they're there and check it. Well, usually we checked them at the first of the month. Yeah. Obviously. And then, you check them.
So, okay, let's say I have a patient that is, because latex is a big allergy for us. A lot of offices have moved away from latex gloves fully, but I've had one patient that didn't realize it and they weren't in anaphylaxis, but their lips definitely got swollen, definitely got a redness. I mean, am I going to stab them with an EpiPen in that case, or am I just Benadryling them?
If they're having trouble breathing, I would say go ahead and use the EpiPen.
All right.
And the thing is, if you use the EpiPen basically with that amount, it's going to help, but also the real just side effect is their heart's just going to beat pretty fast and they're going to feel funny and weird for a while. I would say, so anaphylaxis, I was going to say the two main things are if they're hypotensive, we determine that as anaphylaxis, or they're basically the same as asthma. If it's wheezing, if you hear wheezing
in the chest,
then definitely use the EpiPen.
Okay. All right.
And there is an allergic reaction. There's some hypertensive medications. There's one that some people will react and their tongue will get really big.
When they take it?
Yes. But it's not necessarily, it mimics like an allergic reaction, but it's a key thing if they're taking, sometimes they said the doctors change them to a new.
Interesting. I wonder if it's the same one that causes gingival hyperplasia.
ACE inhibitors. So like enalapril, lisinopril, and the ills.
Any of the ills.
Yeah.
If they're taking that, they can, and they're new to taking this, is that what you're saying? They could mimic.
It causes angioedema is what it's called. So the tongue just gets huge. But they don't really have any trouble breathing or anything.
They're just tongue
and I think Benadryl does treat that as well. But yes, a lot of the times you kind of learn as you go type thing. You would see people and I'm immediately think allergic reaction. And then as soon as you're asking blood pressure medicines, because they're not having any of the other difficulties that.
Interesting. Because we look at people's tongues all the time. Never thought about that. So let's talk about diabetic patients, because Lord knows we got more diabetic patients, and
especially in the South.
Yes. I mean, both the butter and the fried food is delicious. So let's talk about that, because it is a very chronic, complex condition, and we are going to have a series, if it hasn't already come out, on type 1, which was very interesting. So one of the things that we definitely always recommend is the dental office having like a blood glucose test kit with the strips available.
Glucometer.
Yeah, glucometer. Thank you. But one thing that I have actually suffered from and had syncope with, unfortunately, is hypoglycemia. So explain to us what hypoglycemia is and what we can do for those patients.
So hypoglycemia is a drop in blood sugar. So usually now as a medic, so we're working under medical control. So we depends on your doctor or what context you're reading is what they define as hypoglycemic. Usually it's 60 or less.
Okay.
Less than 60.
Okay.
So on the glucometer and you're checking their sugar, which is in milligrams per deciliter, if you wanted to know that.
I don't, but go ahead.
I don't either. So if it's less than 60, we term that hypoglycemic.
Okay.
And they keep changing the normal ranges for sugars for just a normal person. I think it's like 70 to 110, maybe.
Okay.
120. Anything technically above the normal range would be hyperglycemic. So, and you can get people with some of our glucometers. It's also good to know how high your glucometer reads. Because a lot of them in the hospital, they can actually test the blood and get an actual number. A lot of the glucometers, once they hit 500, it'll just say high. It'll read high. And
will register 500. Oh, Jesus.
Yes. So it depends on the glucometer. So it's always good to know. So if you get a high reading, so you can say, well, how far up does the glucometer read? Does that mean it's above 400? So
at that point, does it matter for us?
It's just high. But the difference is, so a lot of people if their blood sugar's high, they're not going to present the same way as low blood sugar. Someone with low blood sugar is going to present, again, people are very different and act different ways. A lot of them will definitely appear intoxicated.
Ah, okay.
It'll be like someone's drunk. They will want to fight you.
What?
Yes. We've come to people and had to literally they're not trying to physically beat you up. They're struggling with you and it's a fight to get.
They're very disoriented.
They're very disoriented. And then some people are just unresponsive, snoring like your dog is over here.
Lola,
I would
check your blood sugar
and do a little check on their finger. Say, oh, it's 50. That's why he's acting like that.
Oh. So would you in this case, let's say they're non-responsive, or maybe we thought that it was syncope and they haven't come back and
check their sugar.
Their sugar, but maybe that's one of the first things that you would be doing because we're checking their blood pressure.
So if someone's unresponsive, that's one of the first things I'm doing is I'm going to check blood sugar, always for unresponsive, as well as, and again, these are multiple things you would do, and you can have multiple people doing
right.
Them. So if somebody's checking blood sugar, somebody's getting a blood pressure and a pulse rate, and watching respiratory rate. I mean, those are the main things.
Okay.
I would say on someone who's unresponsive.
So I know we're kind of bouncing around a little bit here, but I'm just curious because, I've grown up in dentistry in an office that was doing sedation dentistry. So we had all the things. We did this pretty routinely. I did dental assisting in these surgical settings. So I feel very comfortable with that. But I'm also out of that setting for like a few years now. So, what would be like... how can you keep yourself steady and trying to remember all these things when you maybe don't practice in that kind of situation at all? So I guess
with the different health issues like diabetes.
Well, let's say like we have this, we have hygienists that are either newbies, they've never had to encounter a situation like this. And first and foremost, we're calling 911 and if we can get them to respond,
right,
turn them on the side, possibly blood pressure,
right,
which we should have available like right around you because hopefully you're doing that in every patient. And the glucometer, respirations, pulse, that's kind of where we're at. As long as we know that, don't get the glucometer before you check their pulse, I guess.
Yeah. Yeah. Have someone go get the glucometer as you're checking pulse.
Okay. That's fair. That's fair.
But technically people can arrest if their sugar's too low.
Oh.
I've had, you also get suicides and suicide attempts working on the ambulance. And I have definitely had someone overdose themselves on insulin attempting to kill themselves.
Oh gosh, that's suicide. Rough.
So, sugar is important. Usually that's not the reason their heart's going to stop, but it can. And that's, if I respond to a call and someone's heart's not beating and someone's doing CPR, that's still a step I'm going to take because I have to rule that out.
Okay.
So there's, something y'all wouldn't know, but when we're working someone cardiac arrest, we go through we call it the 5 H's and T's, which are different reasons someone can arrest. And some of the reasons we can't technically fix, but it helps us to think through them, like hypovolemia. Okay. Are they bleeding? Are they whatever? I can give them fluids. Hypoglycemia is one of them. So if that's something I can fix, I fix it and I move on. So that's definitely important.
How are you fixing hypoglycemia on a truck like that?
So on a truck, I don't know what they do now because I don't work on a truck, but we never carried like oral glucose, which usually comes in a tube, or you can get oral glucose tablets, which you can give to someone so they can actually just squirt it in their mouth and the gums, and it seeps in, obviously, in the blood vessels in your mouth, and they can swallow
like under the tongue.
Yeah. It's just a little tube, looks like a toothpaste tube, and it's just glucose. It's really sweet, or tablets. We used to not carry those on the ambulance, but I think they might now. But what we would do if we responded to someone and their sugar was low and they were a little disoriented, but they could still talk to me and I was not concerned about their swallowing, I would make them a peanut butter and jelly sandwich or fix a glass of orange juice, add some sugar to it, whatever they had in their house that they could eat. Okay. So, but obviously if someone's unresponsive or even if they're that disoriented where you're concerned about their swallowing, don't give them anything. And a lot of times you will respond to calls and people have just poured something in someone's mouth. That's not a good idea. So even if you have the oral glucose, if your dental office happens to carry it and someone's unresponsive, don't just squirt it in your mouth because then you're possibly causing another problem. They might aspirate.
Right, aspirate. Right.
So what we did was we gave D50, which is through an IV. So we would get an IV and it's a huge syringe because it's really thick. It's basically saline with a bunch of glucose, D50 dextrose. Okay. So we would push that and they would wake up really quickly.
Wow.
Usually.
It's like that fast.
And then we'd check their shit. It's pretty fast. If we couldn't get an IV, there's also something you can give called glucagon, and it's just IM medication.
But these aren't things that we would have in our typical medical emergency kit, though,
Probably
right?
not. You could possibly, I think I saw something on your screen about maybe glucagon, because that's something you can just give IM. Okay. Kind of like the epi
And IM meaning we're stabbing it into the muscle. Mm-hmm. Okay. And then, I mean, we've definitely heard of keeping like juice boxes and things like that. But of course, like you said, that's a good point to make. And if they're not responsive, that's probably not a good plan. Yeah. So keep that in mind, folks. I do want to move on I want to knock out seizures. I would love to knock out stroke and heart attack. But I'm also curious too about partial airway obstruction because we're working in that mouth.
Right.
Things can drop down there all the time. But let's take seizures first.
Okay.
So what am I looking for?
So there's all types of seizures. And some people can even have, it's called like, gosh, it's been so long since I worked on this, where like just their arm will move around. And I'm going blank on the name of that. I can look it up later. But it's a different type of seizure. That's not usually a huge deal because they're still conscious and able to talk to you. But usually your main seizures that people see are the grand mal or whatever seizures. And a lot of people get this aura, so they can almost tell you when it's coming on, or they can kind of tell that it's going to come on. But if someone has a seizure, usually it's their entire body's convulsing. I know like a really old school thing was to stick a spoon or something in their mouth.
In their mouth.
Don't do that.
Don't put your fingers in their mouth.
Don't do that.
Don't grab their tongue.
People that have seizures, it's going to last a little bit. It is a scary thing to see.
Right.
I would just say if they're in the dental chair and you think they're safe where they're not going to fall out, again, Adam not as familiar. I mean, know what a dental chair looks like, but just leave them there.
Okay.
But if, usually you don't want to move someone who's seizing. And I think they're probably pretty safe in a dental chair until they stop seizing. If they're on the floor or something, we would always if there's a table nearby, they can crack their head on, move anything around them so they don't hit it.
Okay.
And a lot of seizure patients will urinate on themselves. So that's a kind of key way to know, as well as they're going to bite their tongue.
Oh.
A lot of times. So if they stick
Which
out
is why
their
you
tongue,
would put the wood spoon between their mouth?
That's why a lot of times people would put something in their mouth. But the problem with that is they can injure their teeth, obviously, if it's something hard. Or
they can still bite themselves.
Or you might cause an airway obstruction.
Okay.
So you don't do that. Just let them bite their tongue. But also the good way, a lot of people will call and say someone had a seizure and it was an episode of syncope. So I could usually, just because I got pretty good at knowing, is not all the times, but if they're wet, they're urinated, or I would say, hey, stick your tongue out. And if they had bit their tongue, that's more characteristic of a seizure, as well as the main difference with syncope and a seizure is when someone wakes up from syncope, if you passed out and you woke up, you would be alert and very oriented.
Okay.
A seizure, someone's very disoriented for usually again, people are different, but usually it could take anywhere from a minute to 10 or 15 minutes till they are oriented again. So that's a key difference if you're not sure if someone had a seizure or syncope. Okay. Because sometimes I've seen people have an episode of syncope that kind of tensed up and they did this flexion, this inward flexion. And so it almost, if you're not familiar with it, looks like a seizure. But that's a good way to know is how alert they are right after.
Okay. All right.
But again, you're not going to treat them any differently unless you're carrying Ativan or something like that, which I doubt.
Some offices might have, but
then you can administer Ativan to stop a seizure.
Oh, I did not know that.
Oh, yeah. Ativan, same thing, lorazepam.
Yeah.
I believe the dose is about, I want to say you can give 1 milligram or 2. I can't remember the exact dose they used to tell us, but that, just because I've been off the truck a lot, and again, it depends on your medical control. And then if that doesn't stop seizing, then you can give them another dose. So yes, Ativan,
okay.
Usually.
So what does that, let's say they have a seizure in our chair, we're going to just move everything away. We're going to kind of get out of their way. Don't put your hands in their mouth. Let it happen. Probably call 911.
Yes. And also it might be hard while they're having a seizure to put oxygen on, but after they stop seizing, if you can put a non-rebreather on, which is the mask, or even a nasal cannula, whatever you have to give them supplemental oxygen, that actually helps them. And a lot of times you can still put it on them when they're seizing. That's going to help them come around a lot faster.
Okay.
So that's, if you have oxygen, obviously, definitely do that.
All right. And then are we laying them like on a side one way or the other in case they vomit or anything like that?
Yeah, I mean, you could. A lot of time, I mean, people don't necessarily vomit when they are seizing, but after they've seized, I mean, obviously you always, with any patient experiencing any kind of medical emergency, you want to try and keep their airway open. So if they're laying flat, a lot of times, the tongue
That
gets
collapses,
in the way.
yeah.
So you're going to have snoring respiration. So if they're in the dental chair, obviously just elevate their head a little bit.
Okay.
That's going to help protect the airway because hopefully it's not going to go directly down. If they're obviously flat, that's why I say just roll them on their side.
Okay.
Because the other thing I was going to say is, do y'all carry OPAs or NPAs, like the oropharyngeal airways?
Depends on the office. If you're like an office that does IV sedation, we even had the nasal trumpets in one of our offices.
Those are always good because an NPA you can use on a conscious, unconscious, any patient.
Right. Okay. Which is pretty much all it's doing is bypassing the oral airway, right?
Yeah.
It's going
and
straight.
it's helping basically still secure an airway.
Okay.
So NPAs are always good because you can use on conscious or unconscious. I mean, it's not going to feel good to a conscious patient, but to a little KY, put it in. And usually they say most people have one nostril that's larger than the other. So try that one first. And you can put in 2 NPAs. But it's just going to help, especially if you have to bag them too, it's helping.
Okay.
An OPA, which is the plastic, you measure from like the corner of the mouth to the angle of the jaw.
I don't know what that is at all.
It's just a plastic piece. Basically, it's got a slight curve. You put it in and basically it keeps the tongue from falling in the back of the mouth.
Oh.
But it's just for unconscious people.
Okay.
But you can insert those and it really helps when you're bagging them. It keeps the tongue out of the way.
Falling out? Interesting.
That would be a good thing to have.
Maybe. Okay. Because I've never heard of that thing before. I would want to do that on general patient care and get their tongue out of my damn way.
Yeah. If they're sedated, you could put it, I mean, now if they're somewhat responsive, a lot of people like it can cause a gag reflex. So obviously if they start gagging, I would take it out.
Sadly, our patients are awake.
Yep.
All right.
Well, it's good to have for emergencies.
That's true. Let's talk MI or angina or cardiac arrest.
Yes.
So let's say a patient, what are some signs of that anyway, first and foremost?
Obviously chest pain, diaphoretic, so profusely sweating, feeling short of breath, lightheadedness. So a lot of women or diabetics don't necessarily feel the chest pain. And I've had people feel weird. I mean, you can even say they had toe pain, something weird.
Toe pain?
And it was like an MI. So women, not necessarily all the time, but a lot of women are not having that characteristic chest pain. They'll call for something else.
Okay.
And they just don't feel right or they're having pain somewhere else. And it's an MI. So just because someone's not having chest pain, but usually crushing chest pain where it feels like an elephant sitting on their chest, diaphoretic, short of breath. A lot of times they'll have left arm pain or tingling, or pain going and radiating into their back.
Okay.
So those are all your, I would say, key symptoms.
And what's my next step if that's a patient in my chair?
Obviously, vital signs, check their blood pressure, keep an eye on their heart rate. If you have a cardiac monitor,
again, a lot of offices will. Yeah.
I was going to say put them on the monitor, but administer aspirin. So baby aspirin is the best. It's chewable. Just make sure they're not allergic to aspirin. A lot of people say they're allergic to it, and a good thing to say is what happens to you when you take it. If it's just because it gives them ulcers or something like that, it's not an allergy. So aspirin is something you can give them if they're having chest pain. Usually baby aspirin come 81 milligram tablets. So 4 of those, 324, that's something they can chew up and swallow and it's not going to hurt them. Oxygen, definitely put them on oxygen, a mask or a cannula because oxygen will help. If you carry nitro,
which is nitroglycerin.
So it comes in tablets or it comes in spray. And if they have history, they might actually carry it.
Yeah.
As well as people with hypertensive crisis or angina, a lot of times will have continual chest pain and they'll take it. So 0.4 milligrams is sublingual tablets. So that's the tablet that they put under their tongue. Or if you carry or they carry spray, you have them open their mouth, lift their tongue up through their mouth, and you spray under their tongue because you just have so many blood vessels there. It soaks it up.
Yep.
So you want to do that. We would always say give one spray, wait about 5 minutes. You want to check their blood pressure because it can bottom out. Nitro can drop your blood pressure.
And isn't there a reaction with Viagra?
Yes. You definitely want to make sure that they're not taking Viagra or any of the other
Erectile dysfunction medication.
And understand too, ask women, because women can be on that for different reasons as well.
Ooh, good point.
Yeah, so definitely ask
Look at me
women.
being so prejudiced against the men.
Yes. And women are on it for different reasons too. It can, oh gosh, that goes into
A whole
else. But
other
like,
thing.
I think it's more like even menopausal type stuff.
Okay.
Like hormone type stuff.
Mm-hmm.
So definitely ask. And a lot of people are embarrassed about it.
Yeah.
Some people aren't, some people are. So a good way to, what I would always do is, because some people are always going to deny that just because they're embarrassed, is kind of look at who's around when you ask it. But if it's an emergency, something like that, and you have to ask, preface it by saying, hey, this medication I'm going to give you could definitely react and cause a lot of harm, because people are more quick to tell you, admit to it if they know that there's a chance it can cause harm. But that was a good point. Definitely ask.
Your heart will explode. Are you on Viagra?
Don't tell them that. But it will. But it can definitely drop their blood pressure. There's also different types of heart attacks, and there's a certain type of myocardial infarction that if the nitro is given, it can bottom out their pressure a lot quicker.
Okay.
So
this is not a more is better situation.
right. So give them nitro, and then. See, even on there, it says every 5 minutes. It says times 3 doses, but
hopefully you have responded by then, right?
Hopefully, because that's about 15 minutes.
Okay.
But I would definitely say, don't just give them medicine and then wait 5 minutes to give them, just definitely check their blood pressure before you give them another dose. Make sure it's staying above 90.
Okay.
If it drops below 90, don't give them another nitro spray. So nitro, so oxygen, aspirin, nitro. We always called it MONA, which was morphine, oxygen, nitro, aspirin, but you guys don't carry morphine. But morphine will open up the vessels as well.
Okay.
And also helps with pain. Nitro should help with pain as well.
Okay. What about stroke? Because I always confuse when I'm going to give them aspirin and when I'm not going to give them aspirin.
Don't want to give a stroke patient.
So tell me the signs of a stroke patient.
So stroke is usually they might have slurred speech. When you tell them to smile, they can also be disoriented. A lot of people know what's going on, which is even scarier to them. I can only imagine not knowing what's going on.
For sure.
But you could possibly see facial drooping on one side. A good way to know that is have them smile. And if one side goes up and the other doesn't.
May be hard if you're actually doing a restorative procedure and you give anesthesia.
Yeah, so that could be hard. But their speech is slurred, which I guess also possibly could be hard. I don't know if they have trouble.
Yeah, I guess that depends on how much anesthesia you get.
And I guess a lot of times we could tell them to stick out their tongue, move it to left and right if they're able to do that. Some people tend to have a conjugate gaze to the right or the left. And if you get them to follow, they can't follow it with your finger. But usually it's facial droop. We always say grip strength.
Okay.
So have them hold your hands and say, squeeze my hands as hard as you can. Usually put 2 fingers in because some people can squeeze really hard and it'll hurt.
Oh, okay. Because they're also desperate. What's wrong with me?
Yeah, people squeeze in there. So give them 2 fingers and say, hey, squeeze my hands. Sometimes they might not be able to squeeze it all on one side, or it's going to be a lot weaker. The other sign it's called the arm drift. So tell them or you can lift their arms up straight out in front of them and tell them to close their eyes and keep their arms straight out. If someone's having a stroke, usually they might not hold up one arm at all, or it might just be a lot lower. You can do that with their feet as well. But usually that's the key thing. We ask someone to smile. You can ask them to say a certain phrase, but that's with the slurring of speech, and just the grip strength is a good way to know.
Okay.
So that's usually, with a clot in the brain, but a lot of people can also have a head bleed. So they might have similar symptoms, but they also can just complain of a horrible headache.
Okay.
The worst headache of their lives. A lot of times, a bleed will present a little differently and with a headache, and they also might just become disoriented or something.
And so what's our next step if obviously I
honestly,
get it. Yeah.
There's not a whole lot. I mean, even on the ambulance, there's not a lot we could do. I mean, things are always progressing, but the biggest thing with stroke and heart attack is time, right? So time is muscle. So heart attack, if you're not getting oxygen to that muscle, it's going to die. Same with the brain. If there's a clot or something, the brain's not being perfused. So they want a quick time, and they're really quick in the ER, getting them to the CT scan and all that. So the quickest thing is just to get the ball rolling. So I would say call 911. You can always put them on oxygen because that's never going to hurt anyone usually. And just a lot of times I say just talking to somebody, they're going to be scared. Their family's going to be scared. Sitting there and talking to them does so much more when you can't actually do anything medical. But really with stroke, there's honestly not a whole lot you can do. I mean, just protect their airway if it gets that bad. I mean, it can progress to where their airway is compromised. So you might have to ventilate them if it gets that bad. But usually, hopefully that's not the case. If they just started presenting with you. But that's unfortunately not a lot you can do with a stroke. Just time. Get them there. Get the ball rolling, I would say. And
I just want to quickly, because I know we're kind of getting to our time, but I want to quickly talk about obstruction, because I would like to then lead into CPR. And this does not count as your CPR training, y'all. Disclosure, go get your CPR. We have to have that with our license. But I would like to know maybe some reassuring things from you as a paramedic, because if we get trained every 2 years, but we don't do it ever.
So
it's intimidating.
It is intimidating. And it's intimidating for anybody for the first time you actually do it. But it's an emergency. There's compression. So you just want to get on their sternum, basically. Keep your elbows locked out. You put the heel of your hand on the sternum, place your other hand above. You just want to really get your body weight over them, because that's going to help, and just compress on their chest. They always say at a rate of 100 to 120 beats a minute.
Staying alive.
They actually said that song is not this, because AHA always changes the rate.
Yeah.
So there's some new song, I don't remember what it is now, that they changed it to. But 100 to 120 a minute. You can sing staying alive out loud. Just
if you need that,
obviously they're teaching in public just to do hands only CPR, so don't even worry about ventilating. But since you're in the office, you have a BVM. Obviously you want to try and ventilate. So with an adult, it's always 30 to 2. Yeah. Whether you have one person or two people. 30 to 2. And that's where an OPA would come in handy, because you could put in an OPA, it would help keep their tongue. And with a BVM,
I feel like that's strongly not going to happen in most dental offices.
It's fine. It's only like 5 cents, but it's fine. They're not that expensive.
Draw the line somewhere. Becoming a nurse.
BVM. So if you have an extra set of hands, I'm sure you're
the little mask. Yes, I actually have one in my car all the time.
So one hand, it's hard to keep a good seal, right?
Small-handed people,
and it's hard for a good seal. So if you have an extra set of hands, what I've realized, people, when there's an emergency going on, people love to be told what to do. They need a job, so give them a job. So if you have an extra person, somebody else can hold the seal while somebody bags. Just give people jobs.
That's actually very interesting.
Tell them to go get some water. You don't even need any. Send somebody to get some water.
Go check and see if the air is still outside.
Just give people a job.
Is there still oxygen outside? If you can go check that.
Feel good. No, seriously, it does help if you can give people jobs, and people are like, okay,
I'll do that.
So also
go wait for the ambulance on the curb.
What I've realized is CPR definitely wears you out, and you don't think it will. So don't be prideful. Recognize your own, if you're tired, switch off. The AHA says switch off every 2 minutes.
But if that adrenaline is pumping,
Yeah. But if you're
think back to you person, being a newbie.
Let me tell you I'm going to tell you. Do CPR. So these new mannequins we have. CrossFit. Yes. But these new mannequins that we have at MUSC's training center, they have a light.
Yes.
And if you're not, have you used those?
Yep.
But actually, do CPR on someone for a couple minutes and you're going to be tired.
Yeah, I agree. I agree.
Now, granted, if you're a big guy who's 250, 6'4", you're going to last longer than you or me because you have more muscle, more weight.
Yeah.
And really they are. But if you're
strong,
tired, it wears you out though. Trust me. I always thought I wouldn't get worn out, and then you're like, okay, I got to switch.
Yeah.
But also because you really do want perfusion. They've realized perfusion is the biggest thing. So if you're not doing good CPR.
What's perfusion?
So when you're pressing on the sternum, obviously it's pressing down on the heart, that it's the blood flow through the body. So when you press on that heart, because the muscle is not actually contracting on its own, you're doing it by pressing down on the sternum, this pushing on the heart to make the blood flow through the body.
Okay.
So perfusion is basically blood flow through the body, perfusing.
And
the main
with
organs.
chest compressions, aren't you kind of forcing that suction of air in because you are compressing on the lungs? You almost get like a rebound, or am I just totally making that up? And
yeah, I don't know about that.
Because I thought I read somewhere where it said that if you are doing those chest compressions, just because you are pressing in,
well, also
they're kind of they're not getting the same amount of oxygen of you or
well, the thing is, blood carries oxygen, right?
Right.
So if you're perfusing blood, even though it might not, you're still like oxygenating sometimes because the blood's carrying the oxygen, and you might get some air in. The other thing to be careful with if you do have someone ventilating is you don't want to over ventilate because it can cause the blood to not return to the heart because and it can cause a gastric distension and all that. Okay. So, you don't want to, you just want to see chest rise.
Yes. And that's it.
And,
not forcing the air into the lungs. So let's say I drop something down someone's throat.
Mm-hmm. What are you going to drop down someone's throat, Michelle?
It could happen. I actually did my... Yeah.
Are they awake?
I will say my very first time of this happening was in an ortho practice when I was 19 years old, just a baby.
So not even of drinking age yet?
Legally. In the U.S.
Okay. Yes, in the U.S.
In the U.S. But we had an instrument that was defective, and the metal, I squeezed down on a bracket, and this thing literally just, like the tip of it flew off and just, like a basketball, like a 3-point shot down her throat. And it was pointed and had jagged edges to it. It was ridiculous. And so, yeah, she went to the hospital, of course, to like get x-rays, make sure it didn't go into her lungs. It went into her stomach. But we've heard stories of people aspirating their partials. Okay. We've heard, people dropping crowns and things like that. So, obviously we know if they swallow it, like what would if they aspirated it, what would be that first sign? They choke, they're coughing.
Yeah. Well, so if someone chokes on something, whether it be food or some type of dental apparatus. If they're actively, obviously they say if someone's choking, they're not getting air in and they're awake, you want to try and do the Heimlich. I would assume that would be the same. If they're actually choking, like having trouble breathing, regardless of what the object is, you want to try and get it out. So you would want to do the Heimlich. If someone goes unresponsive after they've been choking, they tell you just to go ahead and do CPR. But with someone like that, if someone's aspirated, they might be able to breathe, but just they're breathing okay. But obviously maybe it's gone down into the lungs, but it's blocking a small part of the lungs. And so they're still able to breathe and oxygenate. It's just not as well. So their saturation. So I would assume y'all would check O2 saturations, right? You would have a finger probe. Some
offices, some
so you can just check. That's always something, speaking of just general emergencies, if you have to throw them on that to see what their oxygen saturation is. But if they're breathing fine, then obviously you're not going to do the Heimlich. But you saw.
So do we need to call you? Should we just take them to the hospital? I know this isn't. She is not giving full medical advice as a disclosure.
Yeah,
but still.
as a disclosure. I would say just in the medical world, just to cover your butt, if you saw something go down there, go ahead and call 911, because if, God forbid, something were to happen when you transported them or you're letting family drive them, then it's going to come back on you.
Yeah,
so
that's a good point.
I would say just to cover your butt and EMS might not be happy about it, but it's fine.
Okay, it'll be fine.
We get called for toenail pain, so it's fine. Just tell us.
Toenail pain. Oh,
Yeah.
I would slap somebody. All right. So just to wrap this up, I'm having a medical emergency. You are my paramedic coming to my dental office. Pretty much we need to have a copy of the medical history. Maybe you said demographic information.
Yeah, demographics. If you have a demographic page, which a lot of medical offices, doctor's offices, and I'm assuming dental offices would obviously have, if you can just print off they call it a face sheet, that would be great because it has their address, all that stuff.
Okay.
Even their insurance. 'Cause we have to do the same thing.
We just working with dental insurance, so we ain't that progressive yet.
So yeah, demographics is great. Medical history, up-to-date medical history.
Thank you.
Up-to-date medications and up-to-date allergies.
Okay.
Another thing I was going to say real quick about airway, because you said something about a sharp object going in their mouth. If something is actually, God forbid, impaled
into the back of their throat.
Yeah. If they're breathing okay, just leave it in. Don't try to take pull it out because if
don't
you
be
pull
a
it
hero.
out, there's bleeding and all kinds of stuff. Let them go, get an x-ray, and then the doctor can decide if. But if they're having trouble breathing, obviously,
we need
go ahead
to
and pull it out so you can.
And then they can aspirate their blood.
I just wanted to say that.
Okay.
Small piece.
All right. So we're going to get an updated medical history.
Yes.
We definitely want to make sure that we know where our blood pressure cuffs are. We know where our oxygen is. We know where our medical emergency kit is. That we are, as a team, probably going through that, making sure everything's up to date and not expired.
And I would say, understand, people in EMS get lazy too. But you learn from your mistakes. And when there is an actual emergency, and I know y'all don't have them all the time, but it's much better to be prepared and know where everything is. So even if you're going through it once a month, at the beginning of the month, to check that expiration date and make sure that all the meds are in there and nobody's pulled it out and used it for something and not replaced it, or you've gotten a replacement. That happens sometimes. And just that you guys don't use it so much. So epi, if you forget the dose, I was telling Michelle earlier, as a paramedic, there's a lot of medicines we use, especially as a flight medic. Would have a quick chart that we would actually have on my name tag that I could flip up real quick, and I would know the kilograms, weight-based, and it would give me the dose. So a lot of times you can just, to take 5 minutes and have a card written up with the doses, where you can just grab it out when there is an emergency because you're not familiar with it and you can just look at it is nice because your mind is not working so well in an emergency.
No. It sounds to me like this is a great thing to do instead of your dentist telling you to clock out between patients if your patient doesn't show. You could be going and doing these things.
Yes.
And reviewing this and making sure that the office is ready, because if you're more, it's like anything. Like if you're actually prepared for it, nothing's probably ever going to happen.
Exactly.
But the moment you're not, you'll have a medical emergency all the dang time.
Yes. So. And it's easy to get lazy, and everybody does it. But you will be thankful when something happens. And it's just good patient care. You would want someone, if you're going to call EMS, you want me to be proficient with my skills and know my doses, right? Not be fumbling around. So same thing, if I go to the dentist, I want, God forbid, an emergency happen, just to know it. And I will say this, to go back to the very beginning, I do remember, and it stands out in my mind, the time we did respond to a dental office, even though I do not remember the total emergency, they were very good. They had all the information. They were able to tell me what happened, and they seemed very knowledgeable and well prepared. So I was pretty impressed.
Okay.
I don't remember the dentist's office.
Darn it.
But it does stick out to
Wouldn't
me.
that have been funny if that was like you and me before we actually met, and it was the dental office, since I had so many ambulances come.
It could have been.
And I was just so prepared, and you were impressed.
It could have been. We should go back.
Which I wish we could. Yeah. All right. So I will tell you guys that if you want to go over, ada.org actually has some decent courses. There are some things that you can pay for, get your medical emergency training. Definitely look this up, check your emergency kit. And, hopefully, fingers crossed, you'll never have to do any of this stuff. Tram, thanks for coming on with me.
You're welcome.
Well, it wasn't so scary, right?
No.
There's two people
this
in
big
this.
mic is a little scary, but...
Well, there's two types of people in the world. The people who actually talk to a mic and those that clam up as soon as... I don't care if you're the most talkative human. Sometimes you put a mic in someone's face and they
I'm
want
not usually the most talkative, but...
Shut your face.
What?
Well, I hope somebody took something from that. And you can obviously tell that we are buddies. And she does not speak or do anything for a living. So I thought it was a really nice, I think she did a great job for not having a typical, like she's not used to like delivering curriculum like that, even though she is a teacher, but still it's a little different when it's on a podcast and everyone freezes up when you put a mic in their face, I swear.
Mm-hmm. Well, I do that with cameras. Whenever I get a camera in my face, I'm like, how do I talk anymore? So
someone this week asked me, they're like, would Andrew, I said I couldn't do a film and something happening in Seattle. And they were like, oh, do you think Andrew would? I was like, Andrew only tolerates when I force him into the camera.
Barely.
So no.
Barely. And I have to have enough like preparation time to like get myself into it. And then it takes 80 takes to get what we need.
And then chug the Red Bull.
And multiple Red Bulls.
So this does count for some CE, and we thank PDT for that. They are the ones that are constantly sponsoring the CE portion of this podcast, and we are really appreciative of them. And if you are going to be at RDH, definitely come check us out when we're at the PDT booth. But if you're walking the floor, stop by, look at the Gleason guide, look at their handles, why they have the little ribs in them. They'll tell you all those details. Just learn a little something about the company, because they are really, truly great human beings and that make great instruments. So we appreciate you guys.
And if you haven't checked out Trivia Dent yet, Trivia Dent, I feel like I'm just kicking everyone's butt. It's not even fair for anyone anymore to play against me. But I think that if you go on Trivia Dent, there's a chance to win some big money. Last month, it was $250. This month, it's $500 you could have won. Every month, they have a new contest. So go sign up and do the fun side of dentistry, the weird questions about mergers and maybe some things that you knew from school, just a random hodgepodge questions. See if you can beat me, though.
And you definitely should approach this as it's trivia. So knock out the 2 questions or 1 question or something that doesn't seem that it's going to work. Don't think too hard about it. Right. But Trivia Dent is the brainchild of Dr. Tony Stefano, and he and I kind of started this. When did we start this? 6 months ago, something like that. We just really want to bring levity to the profession, and you can win some prizes. But you just go and sign up to be a member. It's $12 for the whole entire year, and you can take once a month this quiz, and then also you can do some online events. And anytime we are at a show where we're doing a showdown, then you can be a part of that, which I think is going to be fun. And I would love to see some RDHs go head to head or teams. And to be very honest with you, a lot of the RDHs are kicking some dentists a booty. So good for you guys. I love it. All right. So we hope everybody has a really great week. And if you're at RDH, come find us.
Truth. All right, everyone. Bye.
Bye, y'all.